What is Case Mix Index? CMI is reported by all providers that report to Medicare and reflects the severity of illness of the patients that you serve. The bottom line, CMI is the measurement of how sick your patients are. Do you really know what is factored into the calculation of CMI? You may be surprised to know that many of the things that impact CMI have nothing to do with coding. The technical definition of CMI is the sum of the relative weights of all the DRGs assigned to Medicare inpatient cases billed by the hospital in a given time frame divided by the total number of cases. The calculation is similar to calculating the grade point average of a student. For example, someone who makes straight A's has a 4.0 average. It is important to note that CMI is calculated from the information billed on the UB. Why is CMI important? CMI measures the cost of resources needed to treat your mix of patients. CMI can reveal how sick your patients really are. And a high CMI indicates the patients are more complex and have utilized costly and/or complex resources. The bottom line, your CMI significantly reflects your reimbursement. Who is CMI important to? The hospital, which includes the C-suite, HIM, and physicians. It's important to the Medicare payer, which in this case is CMS, and basically everyone else, which includes the public and other payers. Why is CMI important to these groups? For the C-suite, HIM, and physician, because as we are switching from volume to value, CMI will aid management in establishing financial liability. CMI can assist in promoting efficient resource management. CMI is considered when planning the annual budget. It can be used for assessing risk. For example, when there's a change in your patient population, CMI can warn of the impending dip in your hospital's income. Performing accurate coding is always important because you want to receive the most appropriate reimbursement for each admission, and accurate coding today foretells the future reimbursement from CMS. It's important to CMS because they will be looking to see who's promoting efficient resource management with the money they have distributed. It's important to payers who like to see the hospitals establish financial liability. The payers are also assessing risk, and commercial payers tend to follow what Medicare does. It is important to the public. Promoting change through accountability, the public is paying closer attention to hospital performance. You may think the process of CMI is out of your control, and in fact, there are situations that affect your CMI where you will have no control. For now, I will show you areas where you can exercise control. One is in the area of strategic growth. You are increasing your medical and surgical admissions. In physician documentation, accurate and appropriate documentation of the admission using a clinical documentation improvement program and physician queries. For HIM, you have coding from the physician documentation. You promote ongoing coding education. Evaluate your AR policy. Is dropping the bill 3 days post-discharge on an incomplete record of better benefit than waiting on more information? Evaluate coding productivity. Knowing the types of cases coming through your facility and your coder skills, is it reasonable to expect all coders to have a productivity of 25 to 30 records a day? In other words, is a coder fresh out of school going to be able to code the same amount of records as a seasoned coder would? DRGs, also referred to as MSDRGs, or Medical Severity DRGs, were revised October 1, 2007 to a 3-tiered system. Here is an example of the 3-tiered system using simple pneumonia, with and without CC-MCC. Notice how the DRG weights differ with a CC and then with a MCC compared with the DRG without CC-MCC. The weights are a reflection of the current national average use of resources for that patient population. For the approximate DRG payment, multiply the relative weight times the blended rate, which is a standardized dollar amount assigned by Medicare, determined by things such as the number of indigent patients your facility sees and the type of your facility, whether it's an urban or rural facility. For this example, I have the blended rate as $5,164.11. Now look at simple pneumonia DRG 193 with MCC. The MCC could be end-stage renal disease. Look at the high relative weight compared to DRG 195. There is a difference here of over $4,000. To get this higher relative weight, the physician must supply the specific documentation. Again, the high relative weight reflects the sicker patients who have utilized more resources. Next, I will show you how to calculate the CMI and evaluate the impact. Here are the same pneumonia DRGs with the addition of chest pain. To calculate the CMI, take the relative weights in the far right column and add them together. Take the sum of the relative weights and divide by 4 because there are 4 DRGs, and the CMI result is 0.94. This is a low CMI, which indicates that these are medical cases that are not complex. There may be an opportunity for improvement, and I will show you how that can be done. Opportunity for improvement can be accomplished by utilizing 2 controls, such as MD query and strategic growth. These are medical and surgical DRGs. I have entered a blended rate of $6,000. For DRG 193, query and the physician changed the principal diagnosis from an unspecified pneumonia to E. coli pneumonia, causing the case to regroup to DRG 177, a higher weighted DRG. Notice the relative weight pre-query and what it changed to after the query. For DRG 195, acute blood loss anemia is a CC. The addition of the CC regrouped this case to 194, a higher weighted DRG. For DRG 254, other vascular procedures without CC-MCC, the addition of Pseudomonas pneumonia, which is a MCC, regrouped this case to 252, a higher weighted DRG. Look at the weights for DRG 193 and 254. Both DRGs include without CC-MCC in the description, but notice the higher weight for DRG 254. The weight is higher because this is a surgical DRG. For DRG 355, hernia procedures except inguinal and femoral without CC-MCC, the addition of a UTI, which is a CC, regrouped this case to DRG 354, a higher weighted DRG. As you can see from this example, by obtaining the most specific documentation from the physician, the hospital can report the most accurate severity, which in turn will capture the most appropriate reimbursement, improving your overall CMI. Just for the record, the CMI pre-query was 1.67, and post-query it calculated it to 3.08. It is important that administration support the investment of time and money in a clinical documentation improvement program in order to make it work. All of this is change that is within your control. Here we will see some issues that are outside of your control. To perform CMI analysis, ask yourself these questions. Did the total medical and/or surgical cases increase or decrease? Maybe you recruited a new internal medicine or surgical group to your campus, or maybe you opened or closed a unit within your hospital. Those would be examples of what would be in your control. But maybe you had a physician practice bought out by another hospital system who recruited your physicians away from your hospital. Did the hospital's overall medical and surgical DRG relative weights increase or decrease? Because the weights change annually, it would be a good idea to review the final rule every October 1 so that you will know what DRGs will make you vulnerable. Was a surgeon on vacation? Let's say your surgeon takes his vacation the same time every year. Referring to last year's CMI during that time period will assist you to financially prepare for his absence. This would be another example of what is in your control. The death of a physician would definitely be a factor that is out of your control. Remember, surgical DRGs are heavier weighted, so if a surgeon is not performing surgery, this would definitely cause a drop in your CMI. All of these issues directly affect your CMI. If we don't work together, this is what could happen. We could end up with a low CMI. A low CMI does not adequately show the resources used and may unfairly misrepresent the complexity of services actually provided. It can reveal poor or inadequate physician documentation. A low CMI reflects no response to physician queries. The bottom line, lower CMI means lower payments. By everyone working together, improving your hospital's CMI can be accomplished today, forecasting a brighter financial future.